This is a review of Chapter 18, or the urinary system. So we're going to talk a little bit about the signs and symptoms that a patient that's experiencing problems in the urinary system can have. The first one is enuresis, which is actually a normal condition. It's involuntary urination by kids usually younger than 4 years old, so that they haven't learned, they're not potty trained yet. And it's different from one kid to another. It's related to their developmental delay, sleeping patterns, and their psychological status. There's incontinence, which would be loss of control of the bladder, loss of voluntary control of the bladder. So these individuals used to be able to control their bladder and they lost it. That's incontinence. So that's the difference between enuresis and incontinence. Enuretic patients are they're not really patients, but they're individuals that were never able to control their bladder. Incontinence would be that they were able to and then they've lost that control. Now, stress incontinence means that they're incontinent when there's a sudden increase in the pressure in the abdomen. For example, during coughing, during sneezing or laughing. And this is actually more common in women because of the multiple pregnancies and childbearing. The next one to talk about is overflow incontinence, which means that there's something wrong with the sphincter of the bladder. It's now incompetent. That could be due to spinal cord injuries or brain damage. And it could also happen in older adults where the detrusor muscles are not strong enough as they used to be, and there's incomplete emptying of the bladder, leading to frequency and incontinence. Frequency means going to the bathroom more frequent. So that these conditions with incompetent bladder, sphincter, or spinal cord injuries, or as we age, these are all causes of overflow incontinence. That means that when the bladder is full, instead of feeling the urge to go to the bathroom, sometimes that urge isn't even there, or the sphincter just lets go on its own. So now the bladder starts contracting on its own, especially if there's spinal cord injury, and that leads to the incontinence. So there's incontinence when their bladder is full, leading to the overflow incontinence stain. Retention of urine means the inability to fully empty the bladder, and that could happen, for example, in males when they have benign prostatic hyperplasia or enlarged prostates, where there's an inability to fully empty the bladder. It can also lead to frequency. And other causes are spinal cord injuries, or it could be caused by anesthesia, whether general or spinal anesthesia. So these individuals can wake up after surgery. Before surgery, they were fully continent. After surgery, their bladders are full, but they are unable to empty their bladder. This is usually a temporary condition, and it usually, just like it was triggered on its own, it'll go on, the body will kind of heal itself, and then it'll disappear on its own. It sometimes takes maybe a few days, up to maybe a week or 10 days. It's kind of a scary condition though for patients, because they wake up out of surgery and they're unable to go to the bathroom. Their bladders are full, so they need to have catheters to make sure that their bladders are constantly being emptied. So what kind of tests could you do for urinary symptoms? First of all is urine analysis. It's not just about the germs or bacteria. You want to take a look at the appearance of urine. So normal urine, you need to know what normal urine looks like to figure out if it's normal or not. So normal urine is straw yellowish in color with a very mild odor. Its specific gravity is a little bit higher than water. So the specific gravity of water is 1. Specific gravity of urine is slightly higher than that of water. It means that it's slightly concentrated, more concentrated than water. But you can see not that much. So if in the case where there's diluted urine, or there's a very low specific gravity, if there's a very high specific gravity, that means that urine is concentrated. It could be simply due to either too much water intake or not enough, so that person is dehydrated. It also can, if that's not the case, it could be due to the inability of the kidney tubules to concentrate urine properly. If you look at the appearance and it's cloudy as opposed to not cloudiness, that could be that there are large amounts of bacteria or pus cells or blood or protein in urine. Blood or hematuria, sometimes if it's there in small amounts, it could even be microscopic. You can't see it with naked eye. You'd have to, you only see the blood cells when you look under a microscope. That could be because of an infection or an inflammation or a tumor in the tract, in the urinary tract. Sometimes larger amounts, though, are visible by the naked eye, and they're caused by the same causes. You could add stones to that as well. Elevated protein levels like proteinuria or albuminuria, that's because of leaking of the albumin or plasma proteins into the filtrate that eventually becomes the urine. Bacteriuria means bacteria in urine, and that's because of an infection somewhere within the urinary tract. Urinary casts are casts of protein. Okay, and they take the shape of different things within the kidney. It's usually more kind of like a protein mold of the kidney tubules, and that means that there's an inflammation somewhere in the kidney tubules. Glucose and ketones should not be present in normal urine, so if they are, that means that that person is diabetic and their diabetes is not under control. Darker color of urine could indicate blood, so it could be hematuria, could indicate that that person has jaundice and they have too much bilirubin in their system and it's leaking into the urine. Or it could just mean that the person is dehydrated and their urine is very highly concentrated. An unpleasant or an unusual odor could be because of infection in the urinary system. Sometimes some medications or even different kinds of food can change the urine, the smell of urine. Some blood tests that you could that could be ordered to diagnose the urinary problems would be kidney function tests. For example, serum urea and serum creatinine levels. Remember, these are poisons that should be eliminated out of the system. So if they're not, and their levels in the blood are high, so they're elevated, serum urea and serum creatinine levels, that indicates a failure to get rid of these nitrogenous wastes, and that is caused by a decrease in the glomerular filtration rate of the kidney. Metabolic acidosis, acid again, or hydrogen ions again, are considered poisonous if it's too much. So again, one of the functions, the normal functions of the kidney would be to get rid of that extra acid if there is a decrease in the glomerular filtration rate, and these tubules are now unable to get rid of that acid. It accumulates in the blood system, in the bloodstream, and that is known as metabolic acidosis. Anemia, that is caused by increased, remember, erythropoietin is made by the kidneys. So if there's a tumor where too much erythropoietin hormone is made by the kidneys, if not enough, if there's a destruction in the kidney and there's not enough erythropoietin being made, that can lead to anemia. It could also be could lead to this suppression in the bone marrow if there is no other cause of anemia. So you need to look at the other causes of anemia first before you can indicate the anemia being caused by a renal disease. Other blood tests would be to check the electrolytes. So remember, one of the functions of the kidneys was to get rid of or maintain a normal balance of sodium, potassium, chloride, magnesium, different electrolytes. So if there's a kidney disease, that could lead to an imbalance of these electrolytes. If you suspect that a person has a rheumatic fever, we talked about that when we were talking about so if somebody is suspected to have rheumatic fever, we talked about this when we were talking about the cardiovascular system, where somebody has a strep throat and then their body starts making antibodies against strep. So now they have anti-streptococcal antibodies, and those immune complexes can circulate in the body and destroy tissues in the heart, and they can also destroy the kidney tissues, and that is known as post-streptococcal glomerulonephritis. So you can check for the level of these antibodies. You can check for the levels of antibodies of anti-streptolysin O or anti-streptolysin kinase. If there's renin levels in the blood is too high, that could lead to hypertension. So remember the renin-angiotensin story where renin comes out of the kidneys. It changes angiotensinogen into angiotensin 1, and that eventually changes into angiotensin 2. And from the name angiotensin, it tenses the blood vessels, leading to hypertension. Another test that could be ordered would be culture and sensitivity studies. So you could take a specimen, a urine sample, and look at it, culture it, look at it under a microscope to kind of figure out, and then figure out what kind of antibiotic would it be sensitive to. You want to do these culture and sensitivity tests before you start any antimicrobial treatment. There are x-rays that could be done, CT, MRIs, ultrasound, IVP, that is intravenous pyelography, where where something is injected through the veins, and then x-rays are taken of the urinary system to kind of indicate any abnormalities or any abnormalities within the system, or you can also take a look at filtration rates and flow patterns. Other tests to be done are, for example, clearance tests, so creatinine and inulin. You can find out how fast or how slow the kidneys get rid of them from your system, and that is used to assess the glomerular filtration rate. Or a scope can be put through the urethra to take a look at the urethra and the urinary bladder. That is known as a cystoscope, and if there's anything there, it could be used to take a biopsy. If there's a small stone it can also be used to remove the stone. In a biopsy to acquire tissue specimen, either through a cystoscope or an open biopsy. Different things that are used to treat different kidney diseases. We've got diuretic drugs, and that is to increase the amount of water being excreted through the kidneys. It's usually done by, remember that water follows salt, which is sodium. So in order to dump more water into urine, you have to dump sodium into urine, and that would passively pull water with it. Okay, and diuretics are prescribed for lots of disorders, not just kidney diseases. They're prescribed mainly for hypertension, congestive heart failure, pulmonary edema, liver diseases. So there's a wide range of diseases where diuretics can be used. Most diuretics are what is known as potassium wasting, meaning that not only do they dump sodium and water into the urine, they also dump potassium, and the body loses the potassium. Sometimes that leads to people cramping when they use diuretics. There are some diuretics known as potassium-sparing diuretics that keep potassium in the system, and I'll talk about one example of that, and that would be aldactone or spironolactone. That is known as the potassium-sparing diuretic. Other, kind of common diuretics used are Lasix or furosemide. There's also mannitol that is given as an IV and injection when you need to decrease when you want to get diuresis, want to use the diuretic therapy on a more faster way. That is done in cerebral edema or glaucoma, which is the increase in the pressure in the eye or increase in the intraocular pressure. Dialysis, that's when there's renal failure and there's accumulation of all of these poisons that need to get out of the body. So urea, creatinine, just too much potassium could be a reason for renal dialysis. All of these, too much hydrogen, all of these, again, these poisons that are supposed to be filtered by the kidney are no longer the kidneys failed, it's not doing that anymore, so now we have to go in and dialyze or filter them out. Okay, so this is used for patients with acute kidney failure, and that is usually a reversible condition, or it's done in end-stage renal failure, which is an irreversible condition, and at that stage they would need, they're put on dialysis until a kidney transplant is available. There are two different kinds of hemodialysis. There is an IV kind and peritoneal kind, and we'll talk about that. Hemodialysis, though, is basically you are using you're putting the patient's blood through a system of filters where all of these poisons are being filtered out, okay? And then you have to return that blood back to them, but it has to be normal in concentration and normal in temperature. Okay? So you have to go through a system of tubes, and these tubes have to be semi-permeable. And there's an exchange of things, so the poisons get out and other things get in, and then everything is returned back to the patient through the veins. So these are the two different kinds of hemodialysis. One, again, is through, the circulatory system. So blood comes out through the arteries. It goes through these dialysis membranes that are semi-permeable. And then all of the poisons kind of diffuse out of these tubes. And then it goes circulated back into the vein. Before it goes back into the vein, there's a bubble trap to trap any air bubbles. Inside this box, or the dialysis unit, there is a fluid known as the dialysis fluid. That dialysis fluid has, needs to be its temperature needs to be the same temperature as the body. It also has to, it needs to keep on. We need to circulate it so that it stays as fresh as possible. So you can see here, there's a fresh dialysis fluid that goes into here first, a temperature bath to make it constant in temperature, almost the same as the body temperature, and it circulates through here, and then all of the used, or the now, quote unquote dirty dialysis fluid is accumulated and then disposed of later. The second kind of dialysis, this has to be done in the hospital. This kind here is known as a peritoneal dialysis, where the semi-permeable membrane is the peritoneum, and this dialysis fluid goes through the abdomen into the peritoneum, and it stays there for a period maybe of overnight, 24 hours, and this can be done at home, and then it kind of washes all of the toxins that are in the body, and then it goes out. There should be another, the picture is missing, the other tube in a dialysis bag where all of the the unclean or the dirty dialysis fluid is captured in there. For dialysis, it usually, especially in end-stage renal failure, usually about 3 times a week, so roughly every other day. Each session takes about 3 to 4 hours, but there are lots of complications, obviously. The shunts can get infected, blood clots can form, the blood vessels could be damaged. The patients are at increased risk of infection, especially hepatitis B or C or HIV, if we don't use standard precautions, which you've learned what the standard precautions are in the lab in AP1 or in AP2. We talked about peritoneal dialysis, and this can be done overnight while sleeping or while the patient is ambulatory and walking. So it's, the dialysis, this is the part where you inject the dialysis fluid through the abdomen into the peritoneal cavity, and it's the peritoneum membrane that acts as the semi-permeable membrane. And then all of that fluid by gravity is drained into another container. For peritoneal dialysis, though, this takes a little bit longer, so it doesn't take 3 to 4 hours. Like I said, it takes maybe up to 24 hours overnight. You need a lot of loose clothing in order to accommodate all these bags of fluid. One major complication is that there's an infection that can happen in the peritoneum, leading to peritonitis. So for both kinds of dialysis, whether it's IV or hemodialysis or peritoneal dialysis, you want to give them prophylactic antibiotics to prevent any kinds of infections. And you want to use caution with many of the drugs because toxic level buildups can occur if these patients are under, have renal failure. Now let's talk about the disorders of the urinary system. First, we'll talk about UTIs, or urinary tract infections. These are very common infections, especially in females, and we know that already from AP2 because of the short urethras. It could be lower urinary tract infection, cystitis, or urethritis. Cystitis would be infection of the urinary bladder, and urethritis is inflammation or an infection of the urethra. There's also upper UTIs like pyelonephritis, and that is an infection in the actual kidney tissue. The most common organism is E. coli, and we already mentioned that it's more common in females. It's also more common in older males because of prostatic hypertrophy and urinary retention caused by that. Another risk factor would be congenital abnormalities in kids. Other common predisposing factors would be incontinence, retention of urine, and direct contamination with fecal material. First, we'll talk about cystitis and urethritis, which are the lower UTIs. And because the bladder is infected, it is a hyperactive bladder with a reduced capacity that leads to frequency. And there's dysuria or pain during urination. Urgency means that person, when they feel they need to go to the bathroom, they need to go now. Nocturia means urination at night. They wake up several times at night to empty their bladders. And they also have the systemic signs of inflammation. So there's the fever, malaise, nausea, and mucositis. Looking at their urine, it's cloudy with an unusual odor. And then if you do an analysis, they can find the bacteria, pus in urine or pyuria, and maybe even microscopic hematuria. Pyelonephritis or upper UTIs, that is where one or both kidneys are involved. Okay, there's usually purulent exudate in that area, so there's usually pus in the pelvis and in the major and minor calyces. If there's recurrent pyelonephritis or recurrent upper UTIs, that could lead to scarring and fibrous tissue, and that scarring or fibrous tissue could lead to the destruction in that area, and see that it's enlarged. And that is known as hydronephrosis. You can see the enlargement of the pelvis and the calyces, and that is, again, because of the scar tissue that is formed, and that leads to a condition known as hydronephrosis, and that can lead to, eventually, to chronic renal failure because it'll compress on the rest of the kidney tissue, destroying them as well. So you also have the signs and symptoms of pyelonephritis. So you have the general symptoms and signs of any infection. You would also have pain in the flank or in the lower back area, which is a dull, aching pain. If you do a urine analysis, it's the same as cystitis, but you have urinary casts. And again, these casts are protein molds of different parts of the kidney, and that indicates an infection or a disease of the renal tubules. In order to treat that, you want to do a culture and sensitivity and start antibacterials accordingly. So these are the infections. In this part of the chapter, we're going to talk about inflammatory disorders, meaning that there's an inflammation of the urinary system not caused by a germ. It could be caused by other things. For example, in this condition, it is an autoimmune disease. So again, you want to make that distinguish between the infections that we just talked about and these inflammatory disorders that are not caused directly by the germs. First one is glomerulonephritis, and from the name you can tell that there's an inflammation of the glomeruli of the nephrons of the kidney. And this is an autoimmune disease. So again, the same patient that has strep throat made antibodies. That antigen-antibody complex circulates in the system, activates the complement system in the body, and leads to this huge inflammatory response in the kidneys. That leads to the destruction of the capillaries in the kidneys and leaking of lots of protein and large numbers of red blood cells in urine. So if you look at the urine, it becomes very dark and cloudy because now there's lots of protein and lots of blood in there. Because of loss of the protein, there will be swelling and edema, especially in the face and around the orbit, around the eyes, so facial and periorbital edema. That's at first, and then later on, if the condition worsens, then there's generalized edema everywhere in the lower limbs, in the abdomen leading to ascites, could even be in the lungs leading to pulmonary edema. Because of all the water that remains inside of their bodies, is now trapped in the bodies, there's elevated or high blood pressure. There's flank or back pain because of the inflammation of the kidneys and the stretching of the renal capsules. You can also find the general signs of inflammation, and there's a decreased urine output. So basically, the kidneys tissue, the glomeruli are destroyed, the renal tubules are destroyed, and a person is unable to get rid of all of that water. Instead, they are getting rid of protein and blood and red blood cells. So all that water is retained within their bodies. For blood testing, you can look at the kidney functions. There will be elevated serum urea and creatinine levels. You can look at the antibodies, and you'll find elevated levels of anti-DNase B, streptococcal antibodies, anti-streptolysin O, and anti-streptokinase. These are all antibodies that you will find elevated within their system. And then there's a decrease of levels of complement because all of the complement system was used in destruction to destroy the kidney tissue. Again, the kidney is unable to get rid of the acid, so there's metabolic acidosis. Upon urine analysis, there's lots of protein, there's lots of blood, and then there's lots of casts, erythrocyte casts. But there's no evidence of infection, so what you are not going to find would be bacteria. You're not going to find pus in urine or any other evidence of infection in urine. In order to treat, remember these individuals are unable to get rid of any extra water, so you want to make sure that they're not trapping more water, so you reduce or even stop sodium in their diet totally. You want to decrease their protein and fluid intakes. For drug treatment, you have to give them, they get large doses of steroids and antihypertensive medications and diuretics to kind of try to literally push the water out of their system. Sometimes if there's too much water in the peritoneum, like ascites, you could do a peritoneal tap where the water is physically tapped out of the peritoneum. Another inflammatory disorder is known as the nephrotic syndrome, and that is an abnormality in the capillaries of the glomeruli. Where the capillaries are destroyed, they've lost those little pores, and now it's leaking everything out of the body, so it's leaking lots of plasma protein. This could happen idiopathically, meaning that there's an unknown reason why this happens sometimes in kids that are between the age of 2 to 6 years of age. It could be secondary due to lupus or exposure to nephrotoxins or drugs. The pathophysiology is that the capillaries are damaged. Lots of protein is now escaping through the kidney out into the urine. There's not enough protein or not enough albumin in the blood, so they have hypoalbuminemia, and that leads to decrease of the plasma osmotic pressure and leads to generalized edema. Okay. On the other hand, their blood pressure is usually within normal limits or even on the lower level. Signs and symptoms of nephrotic syndrome include proteinuria. Remember, protein is leaking out of the urine. Lipiduria and casts. Again, casts tells us that there's actually something wrong with the kidney tissue. There's massive edema throughout the body, and there's a sudden increase in girth, meaning that if you measure the circumference of their abdomen, that there's a sudden increase in that. It's kind of like their abdomen's just distended or extended suddenly. To treat it, to reduce the inflammation, steroids as usual, ACE inhibitors to decrease the protein loss in urine, use antihypertensive medications, and then you want to restrict their sodium intake as well. Now we'll talk a little bit about urinary tract obstructions. We'll talk about urolithiasis, or calculi, or stones. And these can develop anywhere in the urinary tract. Stones can be very small in size and they can pass on their own, or they can be very large and they need a little bit of help to get out. They tend to form if there is excessive amounts of solutes, which would be crystals in the urine, or if the person is dehydrated or not taking in enough fluids, or if they're recurrent infections. UTIs also help in the formation of stones. Stones could be made out of calcium. Okay, so there's high calcium levels in urine, and that usually happens in alkalinic urine. On the other hand, if the urine is usually on the acidic side, that leads to uric acid stones, and that if there's too much uric acid in the urine and blood, that is known as hyperuricemia, and that happens in conditions of gout. Individuals that take too much meat protein in their diet, so high purine diets or cancer chemotherapy, can also lead to that. Other kinds of stones are struvite stones. These are less common though than the calcium and the uric acid. The manifestations of the stones, it also kind of depends on how big the stone is and where, if it causes an obstruction and where that obstruction is. Just like stones are caused by infection, they can also lead to an infection. Hydronephrosis can happen, leading to the dilation of the calyces and destruction of the kidney tissue. If the stone is found in the kidney or in the ureter, it could lead to atrophy of renal tissue because, again, of the development of hydronephrosis. You can see here, this is a hydronephrosis in a diagram, and this is a pathological specimen of hydronephrosis, and you see that the pelvis and the calyces are dilated. Most probably this individual could have had a stone in here that led to the accumulation of urine. Now urine is stuck, it can't pass through the ureter, so it's stuck in the pelvis and it keeps on compressing on these calyces and destroying the kidney tissue. Stones in kidney or bladder can be asymptomatic, especially if they're very small. They could lead to sometimes some flank pain, which would be pain on the sides, especially if there's anything causing distension or stretch of the renal capsule. Renal colics are a problem if there's obstruction of the ureter. So ureter has smooth muscles, and it will try by peristalsis, or by wavy movements, it will try to push the stone through, and these peristaltic movements are extremely painful, and that's what is known as renal colic. The pain is usually in the flank and radiates into the groin area, so it kind of takes the route of the ureter. There could be possible nausea and vomiting, and cool, moist skin, and rapid pulse or tachycardia. And then if an x-ray is done, it could confirm the location of the stone, especially if the stone is made out of calcium. It'll show up on an x-ray. In order to treat, small stones are usually passed eventually. During that phase, you want to give them something for the pain. You want to get them well hydrated so that they're making more urine, trying to kind of flush that stone out. Or if it's too big, we can do what is known as ESWL, or extracorporeal shockwave lithotripsy, or giving waves to that stone from the outside of the body, and that's why it's known as extracorporeal, and trying to break that stone using shock waves. So extracorporeal means outside of the body. Shockwave, lithotripsy, litho would be the stone, and tripsy means to break it down. Or you can do laser lithotripsy, or you can do some drugs to dissolve the stones. If that doesn't work, then you'd have to do surgical procedure in order to get the stone out. Let's try to prevent stones from happening, so make sure that person is always well hydrated, consistent increase in fluid intake. You want to adjust the pH of urine, so remember we said some stones are made if the urine is too acidic, others if the urine is too alkalinic, so you want to make sure that urine pH is constant through dietary modifications. And then treat any underlying conditions, so if there are if there's a condition leading to hypercalcemia that could lead to these calcium stones, so try to treat that condition, and that will prevent stones from happening. Hydronephrosis, we already talked about that. It is a secondary problem. It doesn't happen on its own. If hydronephrosis happens, that means that there's something in the kidney that has led to hydronephrosis. It could be, like we said, a complication of stones. It could be a tumor or scar tissue in the kidney or ureter blocking the passage of urine, leading to the dilation of the pelvis and calyces and destroying the renal tissue. In the early stages, it's asymptomatic. It can be diagnosed with an ultrasound, a CT, or a scan of the kidney. If the cause is not removed, it will eventually lead to chronic renal failure. Now for tumors of the urinary system, there's renal cell carcinoma. It is a primary tumor that comes out of the tubules or the epithelium of the renal tubules. It's usually found in the renal cortex, not in the renal medulla. It is symptomatic in early stages, but by the time of diagnosis, it's usually metastasized already to the liver, lung, bone, or CNS. It tends to happen more frequently in men, especially if they're smokers. The treatment is removal of the kidney. If it is metastasized, you'd have to maybe go through other methods to kill the other tissue. Immunotherapy may be used in some conditions, maiming to try to get the person's or the individual's immune system to kill it. Unfortunately, though, the tumor is radio-resistant, meaning it does not respond to radiation and usually doesn't even respond to chemotherapy, so it is the prognosis is not very good. Manifestations of renal cell carcinoma, there's painless hematuria, and that is, I have it bold and underlined because painless hematuria means that there's blood in urine without any pain, is a red flag, and it's considered cancer in the urinary system until proven otherwise. So you want to, hematuria caused maybe by an infection, by a stone, by an inflammation. All these are painful hematuria. So the patient comes in, they have blood in urine, and there's pain. But painless hematuria could be an indication, again, is a red flag for cancer, and it's considered cancer within the urinary system until proven otherwise. There might be some dull, aching flank pain. There could be a palpable mass if the tumor is big enough. There could be unexplained weight loss, anemia, or erythrocytosis. The individual could have paraneoplastic syndrome, which means again that they have the tumor is making a hormone leading to systemic manifestations. So in this case, hypercalcemia or Cushing syndrome. So it could be that the tumor is making parathyroid hormone, or is making cortisone, leading to hypercalcemia or Cushing syndrome. The second tumor to talk about is cancer of the urinary bladder. And remember, the urinary bladder is lined with transitional epithelium, so this cancer bladder would usually be cancer of the transitional epithelium of the bladder. It often develops as multiple tumors. In order to diagnose it, again, there's usually hematuria, which is painless, dysuria. Sometimes there's a little bit of pain during urination or burning during urination. Infections are common because of the tumor. To diagnose it, there's a urine analysis, the usual stuff that is done for any urinary tract disease. There's also a cystoscope could be done, so to scope the bladder and then take a biopsy if there's an ulcer in there, or if it's after see a mass or an ulcer. And then the tumor invades through the wall of the urinary bladder and then goes to the structures that are around it, so it can metastasize to the pelvic lymph nodes or the liver and even the bone. Predisposing factor for bladder cancer would be working with chemicals, for example, aniline dyes, rubber, and aluminum. Cigarette smoking, so we see that cigarette smoking, not only is it a risk factor for lung cancer, but we see it as a risk factor for kidney cancer and bladder cancer. Recurrent infections and then heavy intakes of analgesics is also a high risk factor for bladder cancer. Treatment, you have to surgically resect the tumor, and then it is responsive to chemotherapy and radiotherapy, unlike the other tumor that we talked about. In this portion, we're going to talk about vascular disorders of the kidney, and those are known as, for example, nephrosclerosis. Remember the term atherosclerosis, where there is damage in the blood vessels of the circulatory system? Nephrosclerosis means the same damage that are happening system-wide is also happening in the blood vessels of the kidney. And some occur normally with aging, just like atherosclerosis, so there's thickening and hardening of the walls of the arterioles and the small arteries of the kidney. That decreases the blood supply to the kidney, and we've agreed that the kidney is not a very smart organ. When there's a decrease in the reduction of the blood supply coming in, it thinks that the body is going through hypotension. It will release renin, and renin again activates that system that leads to increased blood pressure. So in order to treat that, we have to give them antihypertensive treatments. They're given diuretics, and then the salt intake needs to be reduced as well. Now for some congenital disorders of the urinary system, there is vesicourethral reflux. Remember that urine goes from kidney to ureter to bladder to urethra, and it should not go the opposite way. In a reflux, that means that it's refluxing in the opposite direction. So it's going from the bladder to the ureter. Another congenital disorder is agenesis, which means the failure of one kidney to develop. So an individual survives with one kidney, which is a survivable condition, by the way, unless anything goes wrong with that one kidney. Actually, an individual can live with a quarter of a kidney. So we have lots of reserve. Hypoplasia is the failure to develop to normal size, so the person has their kidneys, but they're hypoplastic. An ectopic kidney is a kidney that is not in its normal position. So remember when we talked about, we haven't talked about it yet, okay, but we will when we talk about the reproductive system. Okay, so we'll talk about the kidneys. The kidneys are actually in utero. They start to develop in the pelvis, and then they go upwards. And that's why they pull, the blood supply, they pull the ureters up, and sometimes if there's something wrong with the ascent of the kidney, that could lead to an ectopic kidney. A horseshoe kidney is this kidney that you see here in the picture. There's fusion of the kidneys in the bottom, and it kind of looks like a horseshoe. Adult polycystic kidney is an autosomal dominant gene abnormality caused by a abnormal gene on chromosome number 16. It usually doesn't develop in kids or young adults. It starts to manifest usually around the age of 40. You can see multiple cysts in the kidney, and they all do not function, obviously. And it leads to an enlarged kidney, but it's not functioning, and eventually leads to chronic renal failure. These individuals do not survive unless they get kidney transplants. They can be diagnosed by an abdominal CT or an MRI. Wilms tumor is a tumor in kids, in the kidneys of kids, and you can see the tumor right here. It's due to a defect in the tumor suppressor gene on chromosome number 11. Sometimes if there are other congenital abnormalities going on besides the Wilms tumor, it's usually a unilateral mass, and it usually manifests as a swelling towards the flank, and sometimes if it's large enough, it could be felt and leads to a little bit of dullness in the abdomen. Unfortunately, though, because the abdomen is pretty big of a cavity, it doesn't manifest itself until later. Sometimes even by the time of diagnosis, there is metastasis to the lungs, and it's a pretty fatal condition. So we'll talk about a little bit about renal failure. There's acute renal failure and chronic renal failure. Acute happens fast, and it is reversible, or it can be reversible. Chronic, on the other hand, is a more slow, progressive failure of the kidney, and it is irreversible. So first of all, we're going to talk about acute renal failure. The causes is acute bilateral kidney disease. Remember that we have lots of reserved kidney tissue, so we can survive with a quarter of a kidney. So unless there is bilateral kidney disease, the patient will not go into acute renal failure. It could be due to severe, prolonged circulatory shock or heart failure. Could be caused by nephrotoxins like certain drugs or chemicals. It could be caused by mechanical obstruction, stones or blood clots or tumors blocking urine flow beyond the kidneys. Acute onset means there's a sudden onset. If you do blood testing, you can find elevated levels of serum, urea, nitrogen, and creatinine. There's also metabolic acidosis and hyperkalemia. These are all manifestations of renal failure. Treatment, you want to identify what the cause is and treat that as soon as possible to prevent any permanent kidney damage. Sometimes they have to go through dialysis in order to control, get rid of the extra urea, creatinine, acid, and potassium that are circulating within their system until their renal functions go back to normal. Chronic renal failure, on the other hand, is a very gradual, irreversible destruction of the kidneys. It takes a longer period of time to happen, and in the early stages it is asymptomatic because they have plenty of reserved kidney tissue. It could result from chronic renal disease, congenital polycystic kidney, systemic disorders, or low level exposure to nephrotoxins over a longer period of time. So individuals that are exposed to large doses of nephrotoxins once might get acute renal failure, while those individuals that are exposed to nephrotoxins low levels every day, so work with these nephrotoxins for years and years, day in and day out, those might develop chronic renal failure. Manifestations of chronic renal failure. To diagnose end-stage renal failure, there is zero or negligible glomerular filtration rate. Everything is retained in the body because the kidney isn't getting rid of anything. So fluids, electrolytes, and wastes are all remaining in the body. We have the 3 A's, the triple A's: azotemia, anemia, and acidosis. Azotemia means that the urea, creatinine remains in the blood. All body systems are affected because these are all, again, toxins. Marked oliguria or anuria. So a sign of renal failure would be that there's no urine being made. These individuals have to go through regular dialysis or undergo kidney transplant in order to maintain their life. Early stages, though, of renal failure would be an increase in urinary output. So they are just leaking everything in the early stages. General signs of renal failure would be anorexia, nausea, anemia, fatigue, unintended weight loss. So people that are losing weight but they're not on a diet, that's what unintended weight loss is. And exercise intolerance. Other early signs are bone marrow depression and impaired cell function because, again, of the toxins that are remaining within the body, and it's caused by the increased wastes and the altered blood chemistry. Complete failure, we kind of talked about a lot of these. So oliguria is a very bad sign when it comes to renal functions. Dry, pruritic or itchy, hyperpigmented skin, easily bruised. Peripheral neuropathy, so again, the nerves in the peripheries, in the lower limbs and the upper limbs are damaged. Impotence in men and menstrual irregularities in women may develop. Encephalopathy means that all of these toxins now are in the brain and they are leading to damage of the brain tissue, leading to what is known as encephalopathy. Congestive heart failure, because of all of the water that is retained within the body. They can also have arrhythmias. Remember, the kidney is supposed to activate vitamin D, so now there is failure to activate vitamin D. Because of the uremia, the high levels of uric acid within the blood system. That uric acid can sometimes even come out on the skin and is known as uremic frost, and it kind of looks like little bits of salt on the skin. And then systemic infections are very common as well. To diagnose that, the patient is anemic, there's acidosis, azotemia, which again are the urea and creatinine levels are high within the system, in their bloodstream. Treatment, well, you have to treat all of these body systems that are affected. So you have to, usually the usual course would be dialysis or kidney transplant, but until they can find a transplant or they can find a donor, you have to maintain hemostasis of the fluids, the electrolytes, and their acid or the pH, which is sometimes very hard to do. You want to give them drugs to stimulate erythropoiesis or to stimulate the bone marrow to produce red blood cells, because now the bone marrow is literally being poisoned by all of the toxins in the system. You want medications to treat any cardiovascular problems, and you want to restrict a little bit fluids and electrolytes and proteins to prevent this condition from worsening. Again, the real treatment would be dialysis, but a permanent treatment would be transplant. And this concludes chapter 18.